welcome back. We are now at the final part of our webinar, which is the live Q&A session. We have two panelists with us, Dr. Azrin and Dr. Amir. A few housekeeping notes once again. Please mute all your mics so as not to interrupt the speakers and also not to be distracting to other users. Please click the link for your registration. This is for the claims of the CPD points. And we have already compiled a list of questions, but if you do have any more coming in, just type in the chat box and we'll try to accommodate. We'll allocate about half an hour for this session. Okay, without any further ado, we will start the Q&A session. I'll pass the screen over to Dr. Azrin and Dr. Amir. First question comes from Dr. Gopinath of EDHKL. How do we calculate for the toxic dose of LA?
Okay, to answer the question, basically we have to go back to our pharmacology days and look for the maximum available toxic dose. For the common drug that we use, for ropivacaine, it is 3 milligrams per kilogram, and for levopivacaine, you can go up to 2.5 milligrams per kilogram. Bearing in mind that most of the blocks that we discussed today are plain blocks, and volume is an important part. So because of that, we need to balance out the mass of drugs being used by tailoring the concentration and also the volume. But for most of the blocks, the minimum volume is about 20 mils, except for antihistamine block, which is 5 to 10. So based on that, if we have average adult 20 mils is sufficient for the blocks that we've discussed. And for analgesic doses, usually we go up to 0.375 for ropi and also 0.25 for levo. So basically, if you go by that, 20 mils of half of the maximum doses should still be safe.
Can I add something on this issue? The manufacturer only recommends the recommended maximal dose, which is depends on the type of the local anesthetic. The recommended maximal dose is there to prevent the concentration after we inject into the body, to prevent the plasma concentration become toxic. Okay, but I have to warn you, any concentration, if you accidentally inject into the intravascular, can lead into local anesthetic systemic toxicity. That's what I want to emphasize on this issue.
Thank you very much. We will proceed to the next question. It comes from Dr. Hasnita from EDHKL as well. How do we dilute and prepare the LA? Address this to Dr. Amir.
I think this question is also related to the previous question. First, to calculate the maximal dose, you have to know or estimate the weight of the patient. Okay, and after taking in consideration the maximum recommended dose, you have to decide how much volume you want to use. Let's say my weight is 80 kilogram, and I'm going to use a local anesthetic that the maximum recommended dose is 2 milligram per kilogram. So I wouldn't exceed 80 times 2 is 160 milligram for that particular local anesthetic. So, and if I need volume of 40 mils, example for fascia iliaca compartment block, so I have to decide. Let's say the preparation of the local anesthetic comes in 0.5%, which is 5 milligram per mil. So So you have to dilute or further the local anesthetic to reach the volume that you want, which is 40 mils. So example, I would quote, let's say we take an example of levobupivacaine, which is 2 milligram per kilogram. It comes in 10 mils of ampule, which is 50 milligram. So if you want to use 3 ampules of which is 150 milligram, so you are still safe, but you need another 10 mils to add into the total local anesthetic to make up into 40 mils, if you can get what I mean. Okay, so the final concentration will be slightly less than the 0.5%. Okay, so how to dilute it? I would recommend it to be diluted in a sterile manner. Use normal saline as the diluent to get the final volume.
Thank you very much. This next question, I think would be interesting to get input from both panelists. It comes from Dr. Khalil from EDHKL. What challenges do you foresee in instituting RA in the emergency department?
I think this is an organizational question. It actually depends on what is the available setup that you have in your hospital. If you have an already established regional anesthesia team in your hospital, then probably you can get them to be actively involved to help you set up a center or facility for RA in your ED. So I think there's a few things that we have to look at: the equipment, the drugs, the facility, the training, and how to set up. I think these are some issues that we had to go through when we first set up. So I think it needs a bit of input from the anesthesia department, and also the administration within the ED itself, and also probably a bit of help from top, from the UGRA to help out. So those are the initial few steps. But once we actually have instructed to manage to get that into place, then the rest is to getting your anesthetic colleagues to help out, to look at how they set up the organizational aspects around it, and what are the guidelines that you have to set up. So those are the things that that needs to be considered. So I guess for the initial step, it will probably be a bit tough, but once you get the first few steps in place, then probably it's going to be helpful later on. But the most important thing is to have a core group of people within that setup to have the same interest and to get start off with the initial few stages. So I guess those are the things that you have to figure out how to overcome: equipments, drugs, training, input from other colleagues. So I guess that's the biggest challenge to start off.
I share common thoughts on this with Dr. Azrin. The core business of emergency department is, I know, it's resuscitation. But I would like to share my personal experience. I had the opportunity to be admitted to yellow zone for a fracture forearm. I think it was a busy night. The yellow zone was like, I think, chaotic. There's no penjarakan social at all, I think, because it's very close. I think they need more space for a busy day. But I was in severe pain. Okay. 15 milligram tramadol did nothing to me. And I had to go for X-ray to get the AP and lateral view. I just couldn't imagine the severe pain that I had. So I think besides resuscitation of patient, I reckon ED doctors has also to look into effective pain relief for the patient. Of course, resuscitation comes first, but I mean, pain relief is also another human thing to look into. So in that situation, busy situation, I know the setback or drawbacks of the organization. This is actually a good organization issue, but you need a lot of effort, conjoined effort from, I think, from other departments as well to tackle this issue. So, but this is actually the first baby step by organizing this workshop towards a very long journey.
Okay, thank you very much. I think what both doctors have said resonates with us in ED, the RAC here. I will keep the advice in mind, definitely as we work closely together. We'll move on to the next question from Dr. Shankar, HRTB ED both. He would like to ask the panel on the opinion in giving intra-articular shoulder injection with lidocaine for shoulder dislocation. Maybe Dr. Azin would like to pick this up.
Honestly, we don't have any experience using intra-articular injections. And most of the patients for shoulder dislocation will not come up for 2 or 3 for procedures. So I guess what I'll be answering is based on typical considerations. So basically, for intraarticular injection with nocaine, we know that there are pain receptors within the capsule and within the joint itself. So probably it would work, but just that it may not be in an optimized condition. For a dislocation to be corrected, you need relaxation of the muscles for you to perform it. So I guess by using just intraarticular injection, it will not provide the optimal condition for you to perform the procedure. And I would probably suggest an additional scaling or superarticular block for you to have better condition to perform the procedure better. Probably in less pain, and also patient will also have extended pain relief for longer hours beyond that. So to have an optimal condition for the procedure, I would suggest to have a block done. Probably if you find intraarticular shoulder injection works, then maybe you can just supplement that with the blocks. Either one of those techniques.
We'll proceed to the next question for Dr. Amin. Dr. Lokman from EDHKL would like to know how you choose the needles and what type of needles are available for use.
Okay. When you decide to choose the needle, a few factors you have to look into. One is the length of the needle. Okay. When you do the scalp scanning, means the preliminary scanning before you perform the real block, you have to decide and approximate the depth of the structure. Okay, so means from the ultrasound window, you have to look whether this structure is superficial or deep. So that's how you decide the length. So usually, I mean, in our population, we don't need more than 100 mm. In average, 80 mm length, needle length would suffice. Okay? So then comes the type of the needle. So there are a few types of needle in the market. One is the normal block needles, the old needles, I would say, the cheap needle. Okay, this needle is designed for not designed for a ultrasound guided clock, so it's not an echogenic needle. So that's why it's cheap. So when it's not designed for echogenic, it's not an echogenic needle. So the image or the clarity of the needle on the ultrasound is not as good as an echogenic needle. So, but it comes with a higher price for an echogenic needle. So, if you have the budget, get an echogenic needle. Okay. So, let's say if you decide on the want to buy which type of needle, I would recommend you buy a slightly longer rather than a shorter needle, because longer needle can be used a superficial block, but shorter needle cannot be used for a deeper block. So it's just safe. I mean, one needle can be used for all blocks. It's just that when you decide, when you perform a superficial block with a longer needle, you have to be careful when you advance the needle, especially if you have a crucial, structures like supraclavicular block, you have a pleura below. When you use a long needle, just be careful that you don't advance too deep. Okay.
Sixth question comes from Dr. Sopina of EDHKL. I think Dr. Azrin can pick this up. It's since hip fractures are common in the elderly population, are there any dose adjustments for the elderly?
I guess when you consider the elderly population, it's basically the pharmacology of the drugs. They have a slower clearance of the drugs, and hence the blocks can last longer. But in terms of those adjustments, I guess for, let's say, hip procedures, if it is for fracture EDHKL or even bank block, the volumes that we use are actually 20 mils roughly, or even for fracture EDHKL block, we can go up to 40. If you have this concern of having slow metabolism and things like that, you probably can just use a more dilute solution. But the volume you still need for the spread. So I think one of the studies done before has mentioned that for you to cover the three nerves, including the obturator nerve, you have to at least give 30 mils, depending on the body habitus of the patient. So you need the volume, but if you have this concern, you can further dilute the drugs to a more dilute concentration. So I guess volume-wise probably it's the same, but you can actually adjust the mass of drugs by adjusting the concentration of the solution that you use.
Right. Dr. Falina from Anaesthesia in HSA JB is a question for Dr. Hamid. Is there any difference in the outcome with different approaches of the fascia EDHKL block?
Okay. To answer to answer Falina's question, I think the different approach of fascia iliaca block is important for post-op analgesia, where you can use suprainguinal or infrainguinal. In terms of ED setting, mainly for analgesia, example for hip fracture or proximal femur fracture, I don't think either suprainguinal or infrainguinal approach make a huge difference. But for post-op analgesia, I would recommend suprainguinal approach because the success rate of blocking the three nerves in the aim of the three nerves, namely the obturator, LFCN, and femoral nerve is higher. When you perform infrainguinal approach, probably you miss the LFCN component or even obturator component. But I would say for ED setting, infrainguinal approach is as good as suprainguinal in terms of analgesia for hip fracture.
Okay, can I just add? I think one of the easiest blocks to learn is the femoral nerve block. So I guess if you perform femoral nerve blocks and also the infrainguinal lateral to medial approach, let's say like a block, it will not be much of a difference. So if you are familiar with femoral nerve blocks, for you to get familiarized with, let's say like a block, you can actually perform the same technique for femoral nerve block, but just give 40 mils of local anesthetic. So basically, the volume plays a part in spread, and for beginners, that is probably the technique, the first technique of choice if you want to learn fascia iliaca block. So I guess it's technically it is easier until you have managed to be comfortable with that and you are comfortable with the sono imaging of the inguinal area, then probably you can proceed. So basically, in terms of technicality, probably the infrainguinal fascia iliaca block approach is easier, but in terms of coverage and efficiency, clinical efficiency, then the suprainguinal is probably better evidence-wise. So I guess those are the small differences between the two approaches.
Can I add a bit more on this? Actually, analgesia for trauma and analgesia for surgery is slightly different. Okay, when there's a bone fracture, you have a break in the periosteum, and that is where the cause of the pain, and immediately there are muscle spasms around. Around that example, femur fracture, you would have all the muscles in the thigh. Okay? If you think carefully, actually the innervation of the femur bone supplied by the femoral nerve and the sciatic nerve. If you really want to give a total analgesia, a good analgesia, you have to block femoral and sciatic actually. But actually, you don't have to do that. By blocking the femoral nerve is enough to give a very good pain relief, because by blocking the femoral nerve, you actually block all the muscles that supply to the bone. Okay, so reduce the spasm, and so your periosteum is not like going to be will be a bit relaxed because of the reduction in muscle spasm. So you know, besides you blocking on the sensation, you are actually reducing the muscle spasm as well. So it's different from the surgical, post-op surgical pain.
Next question is also from Dr. Farina. To Dr. Azrin. How do you determine the level of injection for ESP block in patient with multiple rib fractures?
Okay, basically for chest part, if you were to perform ESP, you have to remember that the ESP is a crucial pain block. So, and there's evidence to suggest that 20 mils of local anesthetic given within this space can actually spread up to cervical and also to the upper abdomen. So the thing is to just make sure that you are actually within the area where you can still see the rhomboids. So if you are in the rhomboids, you can see the rhomboids are still within your field of vision. Then it is safe to assume that you are covering the thoracic part of the blocks. So depending on which level, so I guess as long as you can manage to still see the rhomboids within the field of vision, then the 20 mils of local anesthetic should be sufficient to provide coverage for multi-segmental blocks, multi-segmental fracture of the ribs. So I guess have to familiarize yourself to make sure that you are able to see the rhomboids.
Okay. Question number 9 comes from Dr. Nadia of EDHKL. How common are complications and how do we manage them?
Okay.
Dr. Amin.
When you talk about complications, there are a few complications. I think usually in a complete RA workshop, we also talk about complications. So there are a few like local anesthetic systemic toxicity, peripheral nerve injury following blocks. Okay, that are the two common complications that people are afraid of. When you ask about how common, I think for talking about LAS or local anesthetic systemic toxicity, for the last 10 years in our setup, we only had once last incident out of probably 10,000 cases. My best guess for 10 years, let's say we did 1,000 to 1,500 cases per year. So 10 years will be at least 10,000 to 15,000 cases. So we only had once. Okay, so that is what we should aim for when we perform the ultrasound guided regional anesthesia, reduction in complications. Okay, when you talk about nerve injury, the report from the papers actually depends on the report. Some paper report the incidence of nerve injury after a block is actually reduced, but some papers report it's not much difference compared to landmark technique. But the total incidence is actually very low, 0.04% to 0.5%, which is, I would accept the risk because it's very low.
For Dr. Azri, this might be indirectly related to the question earlier on, but the question is which type of block, ESP or the serratus plate block, more suitable for anterior versus posterior rib fracture?
I think if you go back to the anatomy, you know where's the coverage and where is the area that you need to provide analgesia. then you can actually perform either one of the block. I guess for a serratus anterior plane and ESP, mainly it covers the lateral branch, and you actually can block parts of the pneumothorax between midline of the clavicle or anteriorly to roughly about mid-scapular spine area. So if the fracture is within this area, then probably providing serratus anterior plane blocks benefit. But if it is slightly more anterior and goes medial to that, two rough guide, then you probably need a ESP. So if it's anterior close to the sternum, or even just slightly medial to the midpoint of the scapula, then probably an ESP is better option rather than a serratus anterior plane. But then again, it depends on the level of expertise, what type of block that you are comfortable with. Then you, at the end of the day, what the technique of choice depends on what you are comfortable with. So I guess it's primarily determined by where is the fracture and whether you can perform SAP or ESP.
Our last question of the day, addressed to Dr. Amin. Is serratus plane block a good option for chest tube insertions?
I would say yes. Okay, and of course you can also perform a rectal spinal plane block, okay, for chest tube insertion, but serratus plane block is good enough. What you have to understand is the innervation of the chest wall. Okay, as long as you can block the nerve supply to the area, that will be a good block.
Thank you.
If you want to perform the block to provide pain relief for the fracture, then it is good to perform ESP. But only if for the chest tube, then it depends where the fracture is. But just for chest tube per se, then yes, SAP is good.
Alright, so that are all the questions for today. Thank you very much, Dr. Amin and Dr. Azrin, for your time. And that concludes the webinar for today. I hope you have found the session very informative and eye-opening. I certainly have. And I can't wait personally to try this in ED. Before we conclude, just final reminders to all participants to register your attendance via the QR code shown on the link. We will put it up shortly. That is auto-generated for the MyCPD portal, but please do check as well. If you're using the MMA portal, please do a manual submission. On behalf of the organizers, I would like to apologize for any shortcomings during the session. Thank you again to all the speakers for sharing your precious time of today to share your knowledge with us. And thank you to all the participants for your attention. Have a pleasant weekend ahead and stay safe. Assalamualaikum. Thank you.